Hi, everybody. I have some models, but also my colleague Peter that you already know from the previous questions. He brought some models, so he can show it to you. Yeah, maybe to start with saying a couple of words about Materialise. Materialise is a company that's based in Belgium. I'm based in the Netherlands, and we are real innovators for 3D printing. So then 3D printing within the Materialise is divided in 3 units. One of the units is the software, the other one is the manufacturing, and the third unit, The third unit is a medical unit, and I'm the part of the medical unit at Materialise. So in the next 15 to 20 minutes, I want to talk to you about how AI is going to enable personalization in the healthcare. And I can start by saying that the personalization is already a part of the expectations for the patients and the surgeons. Yeah, it's better. Yeah, I think so. So the personalization is already the real expectation that the patients and the surgeons have. And the main examples can be already personalized implants because they are already available for the wide number of applications. The surgical planning that also can be linked already to what's happening inside of the operation room, like the imaging systems inside of the operation room, but also the robotics. And the third example can be that the interactions with the patients are already happening outside of the hospital very widely because there are apps that are used by the physicians to track what is happening with the patient and to allow for a better personalized care for this patient. So all these measures for personalized healthcare are actually targeting the need for a better care because there is this need, and I'm going to talk more about it. And actually, just to say before I continue, I was wondering why this presentation was placed at this part of the day, but now I understand it much better after I've seen what you've all shown this morning. So we talked a lot about the personalization. They probably will wrap it up and talk about the possible next steps of it. So the term mass personalization, on one hand, it's quite contradictory because on one hand we have personalization, so that it implies something that is created specifically for you. And on the other hand is mass, so it's a scalability. And actually these two words together, they make an image for a perfect healthcare idea of the future. Now, of course, it's nice, I think, always to base it on a real use cases. So here there is use case. Imagine you are a pediatric cardiologist and you have a couple that is visiting you and you have to give the news that the baby that was recently born has the heart defect. And then this defect is quite complex and it's because of the aorta and the pulmonary arteries are raising from the right ventricle of the heart. This leaves the large hole in the heart, and this defect is called the ventricular septal defect. You know it because of the low-dose CT scan that was obtained, and you could see the CT scan, and that's your conclusion. But actually, taking into account that the heart of the baby is as small as the walnut, so it's a bit larger. But you could see it, but you don't have the model. You just base your reflection on the images that you've seen. And you have to explain it, for example, to the team that is going to be working together with you. So there are some questions that probably will be popping up in your head. And what would be the question? So what does this defect look like in real life? Can we repair this, or do we need to try and do we need to operate it? There is an extra. Can we fix this problem using a single procedure? So instead of going to multiple procedures, what should or can I expect that will happen during the surgery? How do I align with the multidisciplinary team that is going to be working together with me? And how do we approach to the surgical procedure and how to explain to the parents what will be done with the baby? Previously, this kind of intervention would be considered as being too risky and maybe sometimes even impossible. But thankfully, today we have a ways to visualize it and actually have a 3D printed model after, as a result. This is a screenshot of Materialise Mimic software. Some of you are familiar with this already. And yeah, so that's how, for example, based on this image, we could get a 3D printed model. And yeah, this is exactly the picture that I showed you of this model. So what we've done is that using the low-dose CT chest CT scan, we've obtained the data file and we produced and delivered an anatomical model for the heart. Within 48 hours is what's delivered to the surgical team. And then the team could make the planning based on this model. As a result, the surgery was performed when the baby was 1 week old. The weight was just over 3.5 kilograms. It was a single procedure, so it allowed not to do multiple procedures, and then every procedure, of course, can be life-threatening and there can be complications. And the clinical outcome was actually ideal, and then the baby could continue the healthy life. So the idea here is that the evolution is happening at the moment in healthcare, and then this evolution, what it hinges on is that actually the technology has to be improved much more than what we have now, but we're moving in the right direction. I think this is a positive message in it. These are some of the pillars of this mass personalization. And what is needed is the predictive planning first. So using the correct software and using the right also engineers that are skilled to make this planning. The cost-effective and scalable operations, is it inside of the hospital or outside of the hospital? The next generation 3D printed devices, so the implants. Personalization at the point of care, so 3D point of care that was mentioned earlier today already. And the regulations, so the medical device regulations, but also the quality management system that has to be a part of the setup in the hospital. This is all important if we want to move to this mass personalization. Of course, there are some challenges, and if just I quickly take you through these challenges, it would be the data logistics. What does it mean is that hospital is a highly protected environment, so all the data that is in the hospital is patient data. And when transferring this data or working with this data, you have to comply with the criteria of the high protection. The data processing, so for example, the segmentation of the images, the conversion into anatomical models, this is also another challenge. The physician input, so the physician has to be working together with the medical engineer and together to create a perfect model. And the manufacturing costs, of course, but the basis of all of it is the planning. Now I want to talk a little bit about the advances in the machine learning. So these advances that we're experiencing right now with the machine learning can actually guide us to take up the information about the cause effect from the data that we have already now. And like this, we can totally redefine the predictability in the planning, which is a great thing. So we use machine learning for automation, but at the same time, machine learning can be used for predictability, to improve the predictability. And once we start to do it, the things become very interesting. So, of course, if we want to move to the digital surgery in the future, what we need to do is to gather as much data as possible. So it has to be pre-op data, intra-op and post-op. And more data you're going to gather and analyze, better prediction you can make afterwards. So let's look at just a more realistic example. Let's look at the automatic segmentation that was done in Materialise. So in 2015, it was 100% manual, and then it would take around 150 minutes to do the segmentation. In 2018, we started to use the automation, and then the time was reduced quite drastically. But then at the moment, we're using already the deep learning, so the AI algorithms, and then the time is reduced to up to 10 minutes. So it's a very big reduction than for the last 6 years, 7 years. If we look at the landmarking, for example, the landmark detection with the ShapeNet, the confidence of the object shape was there, but there was no confidence for the landmarks itself. But then with the UNet, you have already the confidence in the landmarking as well, even though it's not 100%, but you have more confidence. So again, the evolution went from the manual until using automation and then the deep learning. So what about the planning? Personalized 3D planning, it's not just the planning, so it's the 3D planning, but at the same time, the creation of the cutting guides, drilling guides, but also of the implants. And then all this is targeted for the patient to have a perfect outcome afterwards, after the surgery. And what you can do is that you can, for example, already pre-visualize the soft tissues after the surgery, and like this, use it as a blueprint for the surgical outcome. So the personalized guides, when you create the personalized guides, you can already take them to the operation room. And of course, when you create personalized implants, this is the best medical device that exists at the moment because it is patient specific. And of course, it allows to have less revisions afterwards, but also to save the bone material. And yeah, there are a lot of advantages. So AI is impacting scalability even in more ways than what I've explained just before. One of the examples can also be image diagnostics. So there are already examples when something was not visible to a human eye, but then AI actually could detect some things within the images. And if we go further and we think also about the future of the healthcare, at the moment, according to the World Health Organization, by 2050, 2 billion of the population are going to be the age 60 and more. And at the moment, so in 2015, it was 900 million. So then the change is quite drastic. And what it means the influence on the healthcare system, and that is going to be suffering because, of course, if you calculate now in the cost of treatments for 85 years old and older is twice the cost for 65 years old and older. But if we compare 85 and 40 years old, it's 8 times more expensive, the treatment. Why? Because of course there are the diseases that the person has become more complex, they pass through multiple revisions, and it's, the cost increases. So this is the reality, and we cannot change it, but we do have to make our healthcare system according to what's happening with the population. And here what I want to say, of course, that the goal is that to treat the patient. At the moment, what we use is the evidence-based medicine, so the medicine that is based on the sciences. And it has to be driven by the evidence, but at the same time, what has to happen is surgeon has now and will have in the future the expertise. So it has to be driven by the evidence, then expert driven together with the surgeon or the medical expert and biomedical engineer that is going to be planning the case, and the driven by the patient data. So then the collection of the data, that's what I already told you about before. To make it more tangible, at the end of the presentation, I wanted to show you, this is our total knee arthroplasty, and this is the AI algorithm that is already developed by Materialise. So what it has proven so far is that with this algorithm, there are 50% less corrections for the preoperative planning, for example, and it has 2 times higher quality according to the physicians or to the experts that were actually working with this algorithm. And also another thing about the algorithm that we're developing is actually that it's surgeon specific. So for example, if the certain surgeon did some intervention before, what we already know is that if the surgeon had a preferred way of approaching, the algorithm would remember it and would apply it for the next surgery that is planned for the specific surgeon. So it's, I think it's quite fascinating. So again, then linking the surgeon planning to the patient data. So it can be done for anatomies, of course, measurements, landmarks, statistical shape modeling, planning, and defect qualifications. So here's just an overview of different services that not just Materialise, but in general we have to be doing for the healthcare. And then it's, in our example, we can power the AI for the R&D, improve the operations, increase the clinical references, and co-create the future, because that's important. What I'm going to do is that the presentation is going to be shared. There are some links that you can check also how AI, for example, AI for enabled segmentation, AI assistant scripting. We also have PACS integration. This is one of the things that we discovered that it was really necessary to be a part of the offering for the hospitals, for instance. And as I said, the presentation is going to be shared. So if someone wants to steal a slide, they can do it. And yeah, here are my contact details if you want to scan the QR code. Thank you very much for the attention, and that's it from my side.